as we talked about this morning, that rotation of the outflow tract is an important part of the abnormalities that we're talking about today. That we'll be talking about later, truncus, and also development of transposition of the great arteries as compared to normally related great arteries. So what we mean by this again is our surgical colleagues' definitions. It's those defects that predominantly have the physiology of uncorrected ventricular-arterial discordant alignments. There are a lot of synonyms that they've listed for this, and the varieties that we're going to talk about are intact septum, TGA with a ventricular septal defect, and with a VSD and left ventricular outflow tract obstruction. So here's an example of one of the things that we often see in TGA. Here's the aorta, which is anterior and to the right, the pulmonary artery there, which is posterior and to the left. And as we turn the specimen around to the left side, you see rather funny appearance of the atrial appendages. This is left juxtaposition of the atrial appendages. This is the left atrial appendage here, and this is the right atrial appendage, more superior, that's come over from the right side onto the left side of the vascular pedicle. And if we reflect the great arteries here up, you can see how this is the right atrial appendage here that comes from the right atrium and comes across just behind the posterior semilunar root and comes to the left side. That's the superior vena cava there into the right atrium, and then the appendage across to the other side. And there's the left atrial appendage just below it, the left atrium there. And when we have left juxtaposition, it's rather common to see a sizable atrial communication like this. Most of these babies have sort of a malalignment between the two parts of the atrial septum, and we see this large atrial communication. That's down to the mitral valve here. Turning back over. The other thing that happens in juxtaposition rather frequently is that the right ventricle is a little small. Notice how anterior the anterior descending is. Usually it would be over here, but it's much more rightward than normal. The left ventricle makes up the apex here, but the right ventricle is a little short. It's a little bit small. So when you see juxtaposed appendages, think about the possibility of a small right ventricle as we have here. Here you're looking into the right ventricle. You can see the tricuspid valve here is rather small. Keep in mind the size of this, and we'll compare it with the mitral valve in a minute. And there's the aortic valve. This is infundibular muscle here, the parietal band, infundibular septum, separating the aortic valve above from the tricuspid valve below down here. So this is typical subaortic infundibular muscle or subaortic conus. Now notice how big this mitral valve is compared to what the tricuspid valve looked like. It's quite a bit bigger. Here's the smooth part of the left ventricular septal surface, trabecular part down here. And here you can see pulmonary to mitral fibrous continuity up here. Here's the pulmonary artery, pulmonary trunk, and branch pulmonary arteries right and left, indicating that this is the pulmonary artery. Now here's another patient with transposition, the PA and the aorta here in the usual position, the aorta anterior and to the right. Here's the foramen ovale, septum secundum, septum primum. This is the coronary sinus ostium here. And then looking into the right ventricle, this patient obviously has a large ventricular septal defect there. And this is in the Y of septal band. Here's the inferior ramus with papillary muscle of the conus. Superior ramus goes up there. And so this is a defect in the Y. This is the infundibular septum up here, which is not fully down into the Y, leaving the ventricular septal defect. So this is a conoventricular type of defect. And here you see the aortic valve leaflet separated from the tricuspid valve by this infundibular muscle here. Then on the left ventricular side, Here you see the free wall papillary muscles here. There's the anterior mitral leaflet here. And the mitral leaflet continues up here with the pulmonary valve. And here's our ventricular septal defect here. Pulmonary to mitral continuity. And in this case, here we see the aorta. We're reflecting it down. We're going to look at the coronary arteries here. There's only one. It's from the posterior sinus here. It's this single coronary ostium here. And it gives rise to the right coronary, which goes over to the right AV groove, and a left coronary, which comes over toward the left AV groove behind the pulmonary trunk. And that's the sinus node artery here, which is often the first branch off of the right. Now we'll turn it around and look at this from the left side. And here you see the pulmonary trunk here, and this is the left coronary artery coming behind the pulmonary trunk from the right coronary, a retropulmonary course, and there's the circumflex by the appendage there, and there's the anterior descending coming down the front in the anterior interventricular groove. So this is a single right coronary artery, or coronary artery from the posterior sinus. Now here's a patient with ventricular septal defect and pulmonary stenosis. That's the aorta there, and there's a small pulmonary artery back here posterior and to the left. I don't know if we can make this any better or not. That's a little better, huh? Let me just go back on this for a second. So there's our aorta up here and the small pulmonary artery back here posterior and to the left there. So typical for the usual type of transposition, detransposition, right-sided aorta. So here's our foramen ovale there. The right ventricle with a large VSD. And notice there's the papillary muscle of the conus. So this is the inferior ramus of septal band here. This is the superior ramus and the body of septal band. And the VSD is there within the Y of septal band. We don't see much of an infundibular septum here. We just go right to aortic valve leaflets up here. There is infundibular muscle here separating the tricuspid valve from the aortic valve. And there are the aortic valve leaflets. There's the third leaflet that's been split up there. But we don't see much infundibular septum. There's one coronary ostium here in this sinus, and there's the other aortic valve leaflet, and there's the other coronary ostium. That's the left, this is the right. Now if we turn this to the left ventricular side, here you see the ventricular septal defect, papillary muscles, anterior mitral leaflet here, and this is the outflow tract, the pulmonary outflow tract here, and this is the infundibular septum right there. It's deviated posteriorly above the left ventricle. This is one of the more frequent causes of subpulmonary stenosis in transposition of the great arteries. And often when the outlet septum is deviated posteriorly, it's fibrous like this. It doesn't have muscle. It never muscularizes for some reason. So there's the pulmonary artery, pulmonary trunk. Behind this, these are quite small because of pulmonary obstruction from the infundibular septum. Here's the trachea. So this is a right aortic arch in this patient. Here's a left-sided innominate artery over here. And as we follow the arch up, you'll see that there's a vessel coming from under surface of the arch here, just after the brachiocephalix, that joins the right pulmonary artery here, and this is a right-sided ductus in a right aortic arch. Most of the time the ductus is left-sided in a right aortic arch, but occasionally we do have a right-sided ductus. Now here's a situation showing that the conal anatomy in transposition can vary. Here's aorta, pulmonary artery, they're about the same level. If we look inside the right ventricle, there's a ventricular septal defect. Here's papillary muscle of the conus, so this is up in the outlet area. Here's a large muscle band here, the parietal band, that's separating the tricuspid valve down here from the aortic valve up here. So there's a large amount of subaortic infundibular muscle in this case. And if we look up into the aorta, here you can see aortic valve leaflets. And this is a coronary ostium here that is the left coronary ostium that comes out left and posterior like normally related great arteries. And when the conus is unusual like this, when there's bilateral conus, we often see this pattern of coronary arteries. The right coronary arises up here, anterior and rightward, almost like what we would expect to see in normally related great arteries. There's the right coronary. Now, we're going to turn now to the left ventricle. And here you can see the anterior mitral leaflet, the smooth septal surface, the posteromedial anterolateral papillary muscle groups here, and the ventricular septal defect right there. And notice that in this case, the pulmonary valve is way up here, separated by this big muscle bundle from the mitral valve down here. So there's infundibular muscle under the pulmonary valve as well as the aortic valve here. And this can actually cause subpulmonary obstruction. So it's important to recognize this when it's present, because it often does cause subpulmonary obstruction, another mechanism. So we're looking at another heart with unusual conal anatomy. In this case, there's bilaterally absent conal muscle. Here's the foramen ovale, coronary sinus. And then as we look into the right ventricle, we'll see the tricuspid valve here. Here's the anterior leaflet of the tricuspid valve, and here's the aorta, aortic valve here. And you can see the tricuspid valve comes right up to the aortic valve. There's no muscle here separating the aortic valve above from the tricuspid valve below. So this is a baby with no subaortic infundibular muscle in the right ventricle here, despite having transposition. This is the aorta. This is the Y of septal band here, and we really don't see a ventricular septal defect in this case. There is a little bit of muscle inserting into it, and there's a parietal band on this side, but nothing in the middle between the tricuspid valve and the aortic valve. Now, there is this other opening that we'll see right up here, right here, into a little anterior infundibular chamber up here. But this chamber has no great vessel coming from it. It's just a smooth-walled chamber, and there's a communication between it and the left ventricle that we'll see back here. Here's the left ventricle, typical smooth septal surface. Here's the left atrium back here, anterior mitral leaflet here. And again, here's the pulmonary valve, pulmonary to mitral fibrous continuity. So there's no conal muscle under either great artery in this heart. And this is the communication that goes up to this little anterior chamber that we saw before. You can go from there into this little chamber here. You can get to it from either ventricle. It's sitting in front of the heart. It doesn't give rise to either great artery. It's just a little blindly ending chamber that can be confusing if you see that on echo. Now, this patient has another problem that we see in some patients with transposition, and that is arch hypoplasia. There's a ductus here coming from the pulmonary trunk into the descending aorta. There's arch hypoplasia and a severe coarctation at that point. Now, here's a patient with a posterior aorta. Just to point out that transposition doesn't mean an anterior aorta. It means the great arteries from the opposite ventricle from normal. So these great arteries look a lot like normally related. But here's opening the right ventricle. Here we see a tiny little infundibular bundle here between the aortic valve and the tricuspid valve. You see how thin that is. It inserts into the Y over here, but doesn't completely fill the Y. That's the papillary muscle of the conus. That's the superior ramus of the Y. And there's the rest of septal band. So there's this very thin little bit there inserting into the Y, but not closing the interventricular foramen. And here's the parietal band onto the anterior wall here, which is quite good size. But the aorta is there, right there, aortic leaflets, tricuspid valve down here. And when we look from the left side, here's the smooth septal surface, free wall papillary muscles. There's the anterior mitral leaflet, and there's the pulmonary valve there, pulmonary to mitral fibrous continuity. There. And you can see this is what should have been the left ventricular outflow tract. The anterior mitral leaflet forms the posterior edge of it, as it usually does for the left ventricular outflow tract. And if we follow this up, it goes to the aortic valve over here on the other side. So this is a sort of an odd kind of transposition. In fact, there's continuity between the aortic valve and the mitral valve through this ventricular septal defect. And in this case, there's a little ductus, but no coarctation. Let me just show you a couple of examples of coronary artery anatomy here in usual transposition. Here's the aorta here, pulmonary artery back here, and yeah, there's the PA. And here's the left coronary here in the front, coming from the left anterior facing sinus, the one adjacent to the pulmonary artery here in the front. And this is the main left, and there's the circumflex going back toward the left AV groove. And this is the anterior descending, and a large ramus branch or first diagonal branch that comes off of the anterior descending right there, almost a trifurcation, which happens not infrequently to see a large ramus branch like that. Now we'll turn around to the right posterior aspect of this aorta here. And here you see that's the pulmonary trunk over there. Here's the aorta, and here's the right coronary. Here's the preventricular branch, and then here's the right main coming down in the right AV groove. So these are usual coronary arteries, and if we look inside the aorta, we'll tip this up a little bit. Here's the left over here. Here's the right back here. These are the two facing sinuses, and the non-facing or non-coronary sinus is the one over here to the right. There's the posterior facing, anterior facing, and the non-facing sinus. Here's the most frequent variation that we see in coronary anatomy in transposition, and that's when the circumflex arises from the right. So there's the aorta, pulmonary artery. And if we look in the front here again, like we saw before, there's the left main coronary, and it comes down out of this anterior facing sinus here, comes down, gives rise to the anterior descending, which comes down the anterior interventricular groove, but there's no circumflex branch coming from this left main coronary. If we reflect the great arteries forward like we did in the other one, here's the right coronary here, and it will give rise to the right main, which goes over in the right AV groove. There's the SA nodal branch. This also has the AV nodal branch that comes from it up here, and this is the circumflex as it comes around in the AV groove on the left side over here. There's the left atrial appendage, and so this is all the circumflex artery here. So now let's take a moment and look at corrected transposition. This is an anomaly that has the great arteries described a malformation in which two ventricles are connected inappropriately to the atria and in which the great arteries are transposed. And you can have it in two ways, one in situs solitus, right atrium right-sided, left atrium left-sided, but RA going to LV to PA. So AV and VA discordance. Same thing over here, left atrium to RV, discordant relation, and RV to aorta, discordance or transposition. And you can have this also in situs inversus. And it's not so infrequent to see this in the setting of situs inversus. The atria are just inverted, just the mirror imagery of what we have over here, still AV and VA discordance or transposition. So here's an example of this. Here's the aorta, which is anterior and leftward, and the pulmonary artery here, posterior and rightward. So just the opposite of what we've seen before in the other patients. And here's our right atrium with the foramen ovale, coronary sinus here. So this is a right atrium, typical pectinate muscle architecture up here of the right atrium. Right-sided right atrium, situs solatus. But now, look, it's going through a mitral valve into a morphologically left ventricle. So we have AV discordance. Smooth septal surface, free wall papillary muscle there and here for the mitral valve. Here's the anterior mitral leaflet, or the medial mitral leaflet, if you will. And you can see there's an outflow tract between this medial leaflet and the septum, and no attachments of the AV valve onto the septum in this case. So there's our pulmonary outflow tract up here. If we turn to the right side, to the left-sided right ventricle, here's the tricuspid valve on the septum. Here's the large infundibular chamber up here from which the aorta arises. These are aortic leaflets here. And here's our tricuspid valve here. And notice, in this case, the basal part of the septal leaflet here is not delaminated. This is like Ebstein's anomaly, and this is a rather frequent occurrence in corrected transposition, where the left AV valve, the tricuspid valve, doesn't fully delaminate from the interventricular septum. You can see it only separates here toward the apex. And this part is all plastered down. This is all atrialized ventricle. There's the anterior leaflet up there. And here's our left atrium with the hammock of septum primum there. So this is a typical left atrium on the left side, situs solatus. Coronary arteries here go with the ventricles, so there's a right-sided left ventricle. And so we would expect to see a right-sided morphologically left coronary. It comes from the right anterior facing sinus here, and there's a circumflex, a marginal, and a large anterior descending artery that comes down the front here. Now, the conus branch often comes from the left coronary, or the morphologically left coronary, in corrected transposition, and comes across in front of this big infundibular chamber that gives rise to the left-sided aorta. And here's the right coronary, left-sided right coronary, coming from the left posterior aspect of the aorta and going down in the left AV groove over here. Here's see the coronary there. There's the left atrial appendage, indicating that this is in the left AV groove. So here's a patient with transposition and ventricular septal defect. Here's the, again, the left-sided anterior aorta. Here, posterior right-sided pulmonary artery here. And if we look into the right atrium, you can see the eustachian valve there. That's the foramen there. And again, here's the coronary sinus. Here's a mitral valve leading into a morphologically left ventricle. Here you see the medial leaflet of the mitral valve. Here's the pulmonary outflow over here. Free wall papillary muscles there and there. And again, there's a ventricular septal defect up there, smooth septal surface. And there's the VSD. And the pulmonary valve is just above the ventricular septal defect, right there. And there's mitral to pulmonary fibrous continuity. So these are the pulmonary valve leaflets. And there's the pulmonary trunk with the right and left pulmonary branches there. There's, again, the ventricular septal defect. If we turn to the right ventricle, left side, well, here's the right atrium, left-sided left atrium. Here you can see the little hammock of septum primum, pulmonary veins coming into the back of the atrium, little left atrial appendage there. And here's the left-sided right ventricle. And here you can see the leaflets of the tricuspid valve. These are not like the other one that we saw. These are much more normal. And there's the ventricular septal defect behind the septal leaflet of the tricuspid valve in a membranous position. There's the the septal band here coming on the interventricular septum. There's the papillary muscle of the conus, and this is infundibular muscle up here under the aortic valve. And here, these are aortic valve leaflets here. Now, if we look at the aortic valve, we'll see that here's one leaflet, and then there's another leaflet over there with a raphe in the middle. So this is a bicuspid aortic valve in corrected transposition. And when we look at the aorta, you see, again, there's hypoplasia of the isthmus and a discrete coarctation of the aorta. And this is a patient with corrected transposition, a large left-sided aorta, small posterior right-sided pulmonary artery with pulmonary stenosis. And again, the reason for the pulmonary stenosis is malalignment of the outlet septum, the infundibular septum here. Here's right atrium with a big atrial septal defect here. Multiple fenestrations in septum primum. Coronary sinus here. Typical right atrial morphology with pectinate muscles, and here's a large eustachian valve that's also multiply fenestrated, so-called Redi network or Redi-Chiari in the right atrium. Here's our mitral valve, and notice that there's a cleft here in the anterior mitral leaflet. When we flip this over, you see that there used to be attachments from this cleft over onto the interventricular septum right there. They were torn post-mortem, but you can see that there were attachments from here to there. The mitral valve used to attach like that, and that would seriously limit flow out the pulmonary outflow tract. So this is another cause of pulmonary stenosis in corrected transposition, and that is abnormal attachments of the mitral valve onto the septum, limiting flow out the outflow tract. There's a ventricular septal defect here, and here's the infundibular septum just below the pulmonary valve, causing subpulmonary stenosis. This is a deviation of the infundibular septum, again above the left ventricle. Here's this multiply fenestrated ASD that we see from the left-sided left atrium. And little left atrial appendage here. And here's our tricuspid valve. Again, this one's fully delaminated. This is not an Epstein. This is the inferior leaflet here, septal leaflet, and anterior leaflet up here. Now, this ventricular septal defect here is completely above the tricuspid valve. It's in the outlet septum. That's the septal band here. Here's the inferior ramus with the papillary muscle of the conus, and the superior ramus there. So this is a deficiency in the Y of septal band because the infundibular septum is hypoplastic and deviated above the left ventricle. Here's our aortic valve leaflets up here. And there. So this is another type of ventricular septal defect that we see in patients with transposition, VSD, and pulmonary stenosis. And this is a corrected transposition in situs inversus. Here, instead of the aorta being to the left, it's to the right. And the little pulmonary artery is back here to the left. There's valvar pulmonary atresia just above the left ventricle there. So now, this is the superior vena cava on the left side. There's situs inversus of the atria. So here you see the superior vena cava, the innominate vein on the left, and here's the innominate vein on the right coming across in front of the aorta to drain to the left-sided superior vena cava. And when we look at the right-sided atrium here, you see that this is a smooth-walled atrium with pulmonary veins draining into it, a small left atrial appendage up here with pectinate muscles confined to the appendage, typical of a left atrium, left atrial appendage. And there you see the smooth left atrial wall when we go through the AV valve here, it's a tricuspid valve. So again, there's AV discordance, left atrium into right ventricle. Here's the medial leaflet of the tricuspid valve, anterior leaflet, inferior leaflet of the tricuspid valve. And here's the aorta up here above this right ventricle, anterior and right-sided. Here you can see the aortic valve leaflets and a large infundibular muscle bundle here, the parietal band outlet septum separating the aortic valve from the tricuspid valve. There's a ventricular septal defect there. And when we come into the left ventricle, see the mitral valve. Here's the left ventricular septal surface here. And notice that the mitral valve has a cleft here as well. You can see the superior and inferior portions of it. And it has attachments here onto the crest of the ventricular septum at the ventricular septal defect. There's no pulmonary outflow because there's pulmonary atresia in this patient. Oops. So finally, just to show you a double outlet right ventricle that's like, with a subpulmonary VSD that's like transposition. Here's the aorta to the right, pulmonary artery to the left, so D-related great arteries, aorta to the right. Here's our right atrium over here. And notice that there's a big Dacron patch in here because this patient had had a palliative mustard operation. Looking in the right ventricle, here you see the septal leaflet of the tricuspid valve here, the anterior leaflet there, inferior leaflet back there. And here's the septal band over here with the inferior ramus, papillary muscle of the conus, and the superior ramus going up here. The ventricular septal defect is there in the Y of septal band. And notice that in this case, there's the ventricular septal defect there. You can go through to the left ventricle there. In this case, the infundibular septum is here. It's out over the right ventricle. It's not back here attached to the superior ramus of septal band like we saw before in the tetralogy of Fallot type 1. Instead, it's deviated out over the right ventricle. In fact, the aortic valve is back here. And so there's the aorta. Here's the infundibular septum. And here's the pulmonary artery up here. And you can see the VSD is now subpulmonary because the infundibular septum out here shields the aorta from seeing the ventricular septal defect. So it's this anterior deviation of infundibular septum that allows this VSD to see the pulmonary valve here instead of the aortic valve. And that's just this little cartoon over here. Instead of being back against the anterior muscular septum, it's deviated out over the ventricle, and so the VSD sees the pulmonary artery instead of the aorta. And I think that's about it. Yep. So that's the story on transposition and transposition type of double outlet right ventricle. And I think it's important to realize the variability in infundibular arrangement that one can see with transposition, because otherwise it can be quite confusing if you find one of these and don't realize that they exist. Oops.
Okay. Well, you've seen from what was just presented that there are a whole lot of variants of transposition. And the ones I'm going to talk about it as I've shown up here. So, firstly, we'll talk about transposition with no other defects, and I'm going to spend most of my time on that topic. And if one looks at the course of a diagram of the circulation in the normal fetus, what you see is what we've talked about to some extent before. The blood is oxygenated in the placenta, comes back to the body through the umbilical vein. Now, the saturations I've shown here, the numbers I've shown for oxygen saturation, are those in the fetal lamb. Just to give you some idea, in the human, we have no idea what the fetal oxygen saturations are. There are no measurements of fetal oxygen saturations, so that whatever I'm going to tell you is my supposition, and you'll just have to accept it for that. But I just wanted to make it quite clear that at the moment, there are only about 3 measurements of oxygen saturation of the umbilical venous blood in the placenta in the human, and this is not in unanesthetized normal pregnant mothers with a fetus. These are in anesthetized mothers, so that we really have no idea what saturations are like. We assume from a lot of information that we have, what I'm going to tell you is pretty much what we assume. But this blood is oxygenated, it's about 85% saturation, and it returns to the vena cava or through the umbilical vein and through the ductus venosus. And then there are 2 streams, as we mentioned, of the well-oxygenated blood, which is directed across the foramina veli into the left atrium and left ventricle. So that in the normal human fetus, we assume that the oxygen saturation of ascending aortic blood is about 65%, which is pretty much what we have in the lamb as well. And because of the fact that the blood going to the right side is more venous blood and less likely to have well-oxygenated blood in it, this oxygen saturation of blood ejected from the right ventricle is about 50%. This goes into the pulmonary artery. Ductus flow is from pulmonary artery to aorta, and this is the saturation in the descending aorta, about 55% compared to 65% in the ascending aorta. So we've talked about this before. Now, when we look at what happens in transposition, we don't have any idea whether the venous flow patterns are different. We assume they're the same, but because of the fact that the pulmonary artery is arising from the left ventricle in the fetus, the saturation of blood going into the pulmonary trunk, instead of being about 50% as it is in the normal, it's much higher, and it's probably close to about 75%. So that the pulmonary artery now is receiving very well oxygenated blood. The blood going from the right ventricle into the aorta, instead of being 65% as in the normal, is now about 45%. So that the blood going from the ascending aorta to the brain and the heart has a much lower oxygen saturation than in the normal fetus. Whereas the blood going to the lungs and also through the ductus arteriosus has a much higher oxygen saturation. Now, I told you before that the pulmonary circulation in the fetus is exquisitely sensitive to changes in oxygenation. And in the normal fetus, the blood is exposed to an oxygen saturation of about 50, a PO2 of about 18. Here it's being exposed to an oxygen saturation of 75 or so, with a PO2 probably in the neighborhood of 25, 26. Now, from studies we've done in fetal lambs, we've shown that the pulmonary vasculature dilates dramatically when the mother is given oxygen to breathe. And the pulmonary vascular resistance drops by as much as 50% with a relatively small increase in oxygen saturation of pulmonary arterial blood. So the effect on the pulmonary circulation is going to be quite dramatic. Excuse me. Now, this means that in the fetus with transposition, where there is a response of the pulmonary circulation to oxygen, there is going to be a marked increase in pulmonary blood flow. And that pulmonary blood flow returns, of course, to the left atrium. Now, one of the things that has been noticed in human fetuses with transposition is that there's a fair incidence of foramen ovale restriction. Now, you can imagine if there's a high flow from the pulmonary venous drainage back into the left atrium, this would increase left atrial pressure and tend to close the foramen. And in studies which were done in human fetuses with transposition at Necker Hospital in Paris, they studied about 120 fetuses with transposition, and they found that about 20% of these had an abnormality of the foramen ovale or of the ductus arteriosus. Now, what about the ductus arteriosus? In other words, either the foramen was restricted or the pulmonary or the ductus arteriosus was constricted. So why the ductus arteriosus? Well, again, you see here that whereas the ductus arteriosus in the normal fetus is being exposed to oxygen saturation of about 45–50%, that's the blood from the pulmonary artery, in transposition, the ductus is now exposed to a saturation of nearly 80%. And we know that a high PO2 constricts the ductus. So that this would be a perfectly reasonable explanation why we're seeing this constriction of the ductus or restriction of the foramen ovale in fetuses with transposition. One thing that's very important to know is that those fetuses with transposition who have either restricted foramen ovale or a constricted ductus do extremely badly after birth. If they are not immediately resuscitated, they will die, and even with resuscitation, many of them die. So that it's bad news if you see a fetus with transposition who has a restricted foramen or a constricted ductus, you better worry about them. So the question is, why is it that this doesn't happen to all babies with transposition? Well, I think there are several reasons. First of all, the response of the pulmonary circulation to oxygen is very gestational dependent. Now, I showed you before in the fetal lamb that the ductus response to oxygen is also gestational dependent. But the pulmonary circulation is also very much gestational dependent in terms of response to oxygen. So that in the fetal lambs, up to about 90 days gestation, which is about 0.6 gestation, which is equivalent to about 30 weeks gestation in the human, to 28–30 weeks gestation, the pulmonary circulation is not very responsive to oxygen. So that if you give oxygen, you won't get much response. So that you'd expect then that in the younger fetus, you may not get as much pulmonary vasodilation. And in fact, this is so in the human, because from studies by Rasmussen and Hutter, they gave oxygen to mothers and looked at, by ultrasound, at pulmonary blood flow in the fetus, and they found that before 25 to 30 weeks, there was no response of the pulmonary circulation to increased oxygenation, but after 30 weeks, there was a definite vasodilatation with oxygen of the pulmonary circulation. So that part of it is gestational dependent. The other aspect that we have to consider is what this whole mechanism here is of flow through the foramen, through the ductus venosus and left hepatic vein, and how much of that blood gets across to the through the foramen, because we know both from studies in the fetal lamb and in fact from studies in early gestation human fetuses that the amount of blood from the umbilical vein that goes through the ductus venosus is very variable. In the sheep fetus, it may vary from 20 to 80%. And in the human fetus, studies we did in very early gestation human fetus, we found that it also varied from about 20 to 30 to 70%. So the amount of blood that goes through the ductus venosus from the umbilical vein may vary, and these factors may influence then whether it's likely that the pulmonary circulation is going to sort of receive very well oxygenated blood or not. Now, I've talked about this. Now, what about the ductus arteriosus? I mentioned that the ductus is exposed to this high oxygenation. Now, if the ductus constricts, then you may expect that pulmonary arterial pressure would go up. We know from studies in fetal lambs, if we constrict the ductus, we get marked elevation of pulmonary arterial pressure. Now, what does this do? Well, pulmonary arterial pressure elevation results in pulmonary vasoconstriction. It's interesting that when you raise pulmonary arterial pressure, you get a response of the pulmonary circulation which results in further constriction of the pulmonary circulation and further rise in pulmonary arterial pressure. Now, if you think about this, what I'm telling you, there's a contradiction, because if the ductus constricts and pulmonary arterial pressure goes up and pulmonary vasoconstriction occurs, then you would tend to get a decrease in pulmonary blood flow. And I've been telling you that the effect on the pulmonary circulation is to increase pulmonary blood flow. So I think we have a question as to a balance between these two in terms of what the pulmonary circulation will do. And I don't know how to determine which is going to be more important. But the one thing we do know is that a certain number of babies with transposition are born with pulmonary hypertension and severe pulmonary vascular disease. The prognosis in these babies is very poor. They are very sick at the time of birth, and they respond very poorly to anything to try to cause pulmonary vasodilatation. But I would suspect that those are babies who have had pulmonary vasoconstriction in utero with a marked elevation of pulmonary arterial pressure and therefore pulmonary vascular disease at the time of birth. There are a couple of observations that support this, that in two babies that were with pulmonary hypertension of the newborn with transposition studied in Holland, they found that on their fetal studies they had constriction of the ductus. So I think it's very important to recognize this potential harm that can be caused by exposure of the pulmonary circulation and the ductus to this high oxygenation in transposition. Now, another interesting issue is what happens to cerebral blood flow and cerebral substrate supply, energy supply. I'd mentioned to you that in the fetus with transposition, you can expect that the aortic blood, the ascending aortic blood, and therefore cerebral arterial blood, may have a saturation which is 20% lower than occurs normally. How important is this? Well, it's interesting that in studies that have been done on head circumference on newborns, the head circumference in babies with transposition is decreased, which has suggested that there is some interference with cerebral development prior to birth. And this is at the time of they born, the head circumference is low. So that the question that has been raised now is there some interference with oxygen supply to the brain? Now, if you know, I don't know if you've know about, we'll talk about it tomorrow, about the measurement of pulsatility index in the cerebral circulation. But what has been found is that in certain congenital heart lesions and in growth retarded fetuses, that there is a decrease in the pulsatility index. On Doppler examination, look at the pattern of blood flow in the anterior cerebral artery, and you find that the pulsatility index is decreased, which suggests that there is something interfering with pulmonary vascular resistance, the decrease of cerebral vascular resistance. Now, in babies with transposition, there are several reports of increased pulsatility index in the cerebral vessels, cerebral arteries, but that has not been generally confirmed. Some people have not been able to confirm that. So, but the thing is that we know from studies in lambs that the cerebral circulation is exquisitely sensitive to change in PO2. And if the PO2 is decreased, there is immediate cerebral vasodilation. And this can be so marked that in fetal lambs, we have dropped PO2s from the normal going to the brain of about 28 to 30 millimeters of mercury. We've dropped it down to 10. And cerebral blood flow increases enough to maintain cerebral oxygen supply adequately, and there's no inadequate oxygen supply to the brain because blood flow increases. And it's the increase in blood flow which is due to the decrease in cerebral vascular resistance, which is also associated with a decreased pulsatility index. So the question that comes up in transposition then is it possible that this decreased oxygenation of blood supply to the brain is interfering with oxygen supply to the brain? I think probably not. But the other important thing to consider, the brain in the fetus as its energy substrate uses exclusively glucose. That's its primary energy substrate. Now, if you think about it, where does glucose come from? Come from the placenta. Now, if you think about this, the placenta delivers the glucose through the umbilical veins. The umbilical veins here are draining into the left side of the heart. In the fetus with transposition, that goes into the lung. So the blood going into ascending aorta would have a decreased glucose content. And I raised the question as to whether that may not be a potential problem, that it's not oxygen because the cerebral vasculature increase its flow, but perhaps glucose concentration that's inadequate. Now, we mentioned that, so we've been talking then about the fetus with transposition with no other defects, or at least no other abnormal defects, because they normally have the ductus and the foramen ovale. But a high percentage of fetuses, of babies with transposition, have a ventricular septal defect. As many as 50% of patients with transposition have a VSD, and it varies in size. But if there is a big ventricular septal defect, you can anticipate that in the fetus, what would happen, because if pulmonary vascular resistance is low, that during systole, because of the flow from the through the VSD, it would tend to be directed towards the pulmonary circulation, so that you'd have flow going from the right ventricle through the VSD into the left ventricle and out the pulmonary circulation. And then, because of the fact that the emptying of the left ventricle would be greater, during diastole you may get some reverse flow. Now, I don't know of any studies in babies with transposition, fetuses in transposition with VSD, but that's what I would predict would happen. And the prediction has been correct in babies without transposition, so I assume that that's probably going to be the pattern of flow. The one thing, of course, that you would recognize is that because of this mixing, there would, within the heart with a ventricular septal defect, there would be some lesser differences in the saturations of blood going to the lungs and the ductus and that going to the brain. So it would even out the saturations to some extent. Now, when there's pulmonary stenosis with a VSD, which occurs in some fetuses with transposition, it's pretty obvious what the flow pattern will be. There will be, with the high resistance to flow out of the left ventricle into the pulmonary artery, blood will flow from the left ventricle into the right ventricle and up into the aorta. And because of this, there will be much less of the separation of the oxygen saturations between the pulmonary artery and the aorta. So, what happens now after birth? Well, obviously, after birth, when you have transposition, the venous blood is going to go out the aorta. So to have the baby survive after birth, you have to have some way for venous blood to get to the lungs to be oxygenated, and you also have to have some way for pulmonary venous blood coming back to the heart, which has been oxygenated, to get to the systemic circulation to provide oxygen to the tissues. So you have to have shunting in both directions. Now, how does this occur? Because we know that babies with transposition do survive at least for a time after birth. So how does this occur? Well, there are two ways in which it occurs. First is, this is when there's no VSD. First of all, the foramen ovale is a very important communication in providing this flow between the two sides of the heart. After birth, when pulmonary blood flow has been established, the left atrial pressure has a high V wave and a low A wave, but the right atrial pressure has a high A wave and a low V wave. So it's possible for bidirectional shunting to occur across the foramen. Now that only is true if the foramen is relatively incompetent. If the foramen is competent, then you cannot get much shunting in either direction. You may get shunting from right to left, but not much left to right. So how else can you get shunting? Well, the ductus is extremely important, the ductus arteriosus. And it's really very important to recognize the role of the ductus in babies with transposition. In the immediate postnatal period, pulmonary vascular resistance will fall with oxygenation. So you'll get an increase in pulmonary blood flow. But the pulmonary, in the first couple of days or so, pulmonary vascular resistance does not fall dramatically. It falls partly, but in transposition, it's interesting that the anatomy of the pulmonary artery is very interesting because there is a very short pulmonary trunk, and the ductus arteriosus arises from this pulmonary trunk a very short distance from the pulmonary valve. So that during systole, the ejection from the left ventricle into the pulmonary artery tends to direct blood through the ductus arteriosus to the descending aorta. So that you get an increase in shunting from right to left during systole. Now, with a low pulmonary vascular resistance, during diastole, blood with the pulmonary vascular resistance lower than systemic vascular resistance, blood flows in the opposite direction. And you can see this very clearly seen in babies with transposition in the first couple of days after birth. You see bidirectional shunting in the ductus. And that provides the mixing. You don't really even need the foramen ovale, because the ductus, at least for a couple of days after birth, can provide adequate mixing. Now, obviously, if you have a baby who during fetal life has developed ductus constriction, they're not going to have that ability to. Yeah, we don't need the windows closed before this. I'm not going to use this much. If you have a baby who has a ductus constricted, they're not going to have this ability to get the bidirectional shunting, and therefore they're in serious trouble. And the same applies to those with foramen ovale restriction. They cannot get any shunting through their foramen ovale. So it's very important to recognize the role of ductus. Now, it's also important to recognize that this is a very important diagnostic aid, because in transposition, the blood, during systole, blood goes from the pulmonary artery through the ductus to the descending aorta. Blood going into the ascending aorta has a low saturation, and a relatively low saturation. But this blood going through the ductus results, with well-oxygenated pulmonary arterial blood, gives a higher oxygen saturation in the lower body than in the upper body. Now, I told you yesterday there were only 3 or 4 conditions in which the oxygen saturation in the lower body is higher than in the upper body in the fetus. We mentioned total pulmonary venous drainage to the superior vena cava. I mentioned transposition. There are 2 other conditions. One is a variation of transposition, double outlet right ventricle of the Taussig-Bing anomaly type, in which the lower body saturation is higher. And there's one other unusual condition, which is great vein of Galen aneurysm. And when we talk about that today or tomorrow or the day after, we'll explain why. But it's very important because if I don't know if you're measuring oxygen saturations routinely in babies, but we do now. And when we find that an oxygen, we always now persuade our neonatologists that they should measure oxygen saturation in both arm and leg, right arm and leg. And if you do this, you will pick up, because the commonest lesion which causes this higher saturation is transposition. So you will pick up babies with transposition if you do this. Now, I think we'll go on. Now, what happens in the baby? So incidentally, just to finish off about those without an associated lesion, the transposition without an associated lesion, if you don't do something further to these babies, when the ductus closes, they will get into trouble. And that's why prostaglandin administration is extremely helpful in babies with transposition without other lesions, because keeping the ductus open allows for this bidirectional shunt. Now, the problem is that this bidirectional shunt will stop as soon as pulmonary vascular resistance has dropped markedly. So after 3 or 4 days, you will not get any right to left shunt through the ductus, because pulmonary vascular resistance is so low that pulmonary arterial pressure falls, and now you will not get that shunt going from pulmonary artery to descending aorta. So it doesn't help after a few days. And that's why prostaglandin is very useful in the first few days after birth, but beyond that, it doesn't help much because pulmonary vascular resistance has fallen. And in fact, prostaglandin itself does produce some decrease in pulmonary vascular resistance. It's not marked, but it has that effect on pulmonary vascular resistance is deleterious in terms of maintaining this bidirectional shunt through the ductus. Now, I'm not going to, I guess I'm getting rather low on time, but I'll just talk very briefly about some of these other lesions. Transposition with VSD, it's a very common lesion, and there's no problem in these babies in terms of mixing, because in the immediate postnatal period, they are often relatively blue because pulmonary blood flow is relatively low and pulmonary vascular resistance is high. But as soon as pulmonary vascular resistance falls, they get an increasing shunt into the pulmonary circulation, and with this admixture of blood, they become quite relatively mildly cyanotic in a short period of time. Within a couple of days, they have only mild cyanosis. And the problem in these babies predominantly is one of high flow with markedly increased left ventricular output, and they develop failure, like any VSD patient, because of the volume loading of the left ventricle. I think I'm going to stop there. What?
Take a few more minutes. If you
Okay. Well, with transposition with pulmonary stenosis, they really present much the way as babies with tetralogy present. Although the pulmonary artery is arising from the left ventricle, the VSD is usually big, so it doesn't make too much difference. They have decreased pulmonary blood flow, they become cyanotic, they depend on ductus arteriosus for maintaining pulmonary blood flow after birth, and they respond very well to prostaglandin. And they have reasonably good mixing because of the VSD. So they really are very similar to babies with tetralogy. And in fact, before, in the days before we used to have ultrasound to make the diagnosis, many of these babies with transposition and PS were carried as tetralogy for long periods of time because they're so similar in presentation. Now, lastly, I just want to talk about an interesting condition which is rare, but occasionally you have a baby who has transposition who has a large atrial septal defect. And because the large atrial septal defect behaves like a huge foramen ovale, these babies do remarkably well. They get very good mixing between the two sides of the circulation. And I have seen a man of 28 who had mild cyanosis, which increased in exercise, but he had transposition with a huge atrial septal defect. So it's just like the patients who, after they've had a balloon atrial septostomy, get increased mixing because of the large foramen ovale. In these patients who have a very big ASD, they do remarkably well. Thank you.
Thanks.
So in conclusion,
Thank you. For the pocket.
so I've allotted myself 30 minutes time for this talk. So what we need to do when we look at this condition with ultrasound is obviously define the ventricular arterial connections and the vessel position, the type and the extent of the atrial connections, perform a balloon atrial septostomy where necessary, define the presence of additional defects, check the coronary artery flow patterns. Okay? And so simply the diagnosis of transposition is easily made by subcostal echocardiography. This is a series of sweeps from the atrial septum showing a very large interatrial communication, the pulmonary artery arising from the left ventricle, and the aorta as we come cranially arising from the right ventricle. Here's a patient who has a ventricular septal defect, and the tissue of the tricuspid valve, because the shunt is going right to left here, is directed towards the pulmonary artery. I've worked with Dr. Rudolph on a patient like this where I diagnosed severe pulmonary stenosis, and indeed all it was the left to right shunt across a fairly restrictive ventricular septal defect. So you have to be careful when you see this, that you realize that it's a ventricular septal defect, shunt rather than a shunt of pulmonary stenosis. But the point of putting this down is to show the clear connection between the left ventricle and the pulmonary artery. Now, by rotating the probe around into the alignment between the vessels, you can see the ductus arteriosus shunt coming across at the pulmonary arterial level here. By the way, most of these patients are neonates, where the diagnosis is really quite critical. And I've matched this up with this example over here. Here's the left ventricle continuous into the pulmonary artery with a slightly more posterior cut and a slightly more anterior cut showing the aorta. And here is that example with
the aorta being anterior and rightward and the pulmonary artery being a little posterior and leftward. Instead of keeping your transducer in the horizontal position, if you rotate it round into the position of the great vessels, you can see the exit of both of the great vessels from their respective ventricles and the ductus arteriosus as well. So that really is very a reasonable way of making the diagnosis. And I put the labels on there for you just in case you were unaware of what I had been. Yes, Dr. Rudolph, there is bidirectional shunting there. This is a 4-year-old here, just interestingly, apropos Dr. Rudolph's connection with a large atrial communication who survived without any additional therapy from the 1970s. And here again you see the aorta coming from the morphologically right ventricle and the pulmonary artery from the morphologically left ventricle with mitral pulmonary continuity. Now we can look at a variety of issues. Here's a patient with a ventricular septal defect. There is some anterior malalignment of the ventricular septum causing a narrowing of the left ventricular outflow tract. This is not uncommonly found when the vessels are in the condition of double outlet right ventricle, although there's mitral pulmonary continuity here, so purists would not call this a Taussig-Bing malformation. And in addition, this patient here demonstrates evidence of subpulmonary obstruction, and here underneath the pulmonary valve you can see this narrowing which relates to this area of subpulmonary obstruction. There's also a ventricular septal defect identified. And when one is in the subcostal position, you sometimes can see that the apex is malrotated round as it is in this patient with dextrocardia, but albeit still with detransposition and delooping present here. Now we can look at the heart from the long axis, and here is again another example. Because there's no twisting that is required in the outflow tract, you can see both exits of both great vessels in a parallel direction. And here's the aorta and here's the pulmonary artery behind it, reminiscent of what we've seen in this patient with the transposition. And here is a patient with a Taussig-Bing type malformation. You can see that there's been double outlet of the right ventricle here. Here's the delimiting coronary artery defining the position of the ventricular septum, and both great arteries are clearly arising from the right ventricle. But reminiscent of what Dr. Rudolph had talked about before, the pulmonary artery trunk is very short, the main pulmonary artery trunk, and the ductus fairly horizontal in its angulation. The aortic end of the ampulla of the ductus is widely patent, and it creates a real problem in these kinds of patients who frequently have aortic arch problems and coarctations. But there's no posterior shelf, and if this ductus were to close, there would be no aortic abnormality, and that's true, but this patient clearly does have a hyperplastic isthmus of the aorta that I've used for comparison. Parasternal short axis allows us the opportunity to look at the great vessels, and the great vessels vary in their position. The aorta is usually a little anterior and to the right, the pulmonary artery posterior and to the left, and there's usually very good alignment between the facing coronary sinuses of the pulmonary artery and the aorta. It's an important sign because when there's malalignment is a much more frequent issue associated with intramural coronary artery and other coronary artery anomalies in this condition. And of course, you can add Doppler color flow in this color compare situation where we have appropriately defined the two-dimensional rather than the color flow picture, and we can see the anatomy as well as the color flow information in its detail. Now, parasternal short axis cuts are the commonest and the most useful for looking at the great vessels. We will not be discussing much in great vessels in this lecture because of the issue of time. I've transferred all of this into the talk on anomalies of the congenital anomalies of the coronary arteries, if you can wait that long. We can also come up a little cranial to where the great vessels are seen, and we can see the bifurcation of the pulmonary artery off this posterior, from this posterior valve, indicating that that's really the pulmonary artery. Now, vessels may not be truly straight or deep transposed. Here's one where the vessels are more in a side-by-side position. Side-by-side position is more commonly associated with coronary artery anomalies. It's more commonly associated with the double outlet right ventricle in true simple transposition. Here is a straightforward front and back view, much larger pulmonary artery than aorta. You can see the origin of the right coronary artery in this cut over here. I don't want to talk too much about it. And we can look down at the vessels in the short axis view and see the position of the ventricular septum. Clearly, there's a volume load over here. The way the ventricular septum is working would suggest that this is a vessel at systemic pressures, and the right ventricle in this patient is even thicker than the left ventricle, suggesting systemic artery pressure. From the four-chamber view, of course, you can see a number of important issues. Here is the ductus arteriosus in the left pulmonary artery. The left pulmonary artery is arising from the main pulmonary artery is arising from the left ventricle. The aorta, seen over here, is rightwardly positioned. This patient has a bulging atrial septum, and very little in the way of intra-atrial communication. However, you can see the tremendously large ventricular septal defect in the septum extending from the inlet septum all the way to the apical muscular septum. We can identify in this view clearly as well the position of the atrial septum and its patency. And also, if we scoot up a little bit towards the pulmonary valve, you can see the coronary artery running over here. As I said, we're not talking about coronary arteries here, but this is a clear sign of a circumflex coming from the right sinus or a single right coronary artery, and I think that's a very important sign. Okay, we can look at the atrioventricular valve relationships. We can see the atrial septal shunting and the position of the pulmonary veins. We can identify position of perimembranous ventricular septal defects again, and also the size of the ventricular septal defects when they're very large. Here, as Dr. Sanders has shown, is a patient with a cleft in the left AV valve. One of the hallmarks of this appearance of the cleft is that the cordon tendinae of this mitral valve are frequently attached to the crest of the septum, and if there is a ventricular septal defect, you can usually follow the tendinous cords to the crest of the membranous septum or of the ventricular septal defect. Sorry. Something happened there. Okay. Here we can see posterior deviation of the outlet septum here, as Dr. Sanders had shown in some of his pathological examples. And you can see I'm sorry, this is not playing and I can't get it to play, the narrowing of this outflow tract here. And in this patient here, we can notice that there's some disparity of the size of the ventricles. You can see by directional shunting of the atrial septum with the cardiac cycle, and a rather small inlet component to the valve with some apical thinning, suggesting a possible apical diverticulum in this patient. Subcostally, we use the tracking of patients. Almost all patients now are getting Rashkin procedures if they need them under ultrasound control. Here comes a subcostal sagittal view with front, back, top, and bottom. And here's the wire going up the superior vena cava. Then we rotate it into the coronal position, and you see the Rashkin catheter tip coming across the atrial septum and going towards the atrial appendage. Here's the balloon being inflated and then jerked across the atrial septum. As Bill Rashkin said, the success of this procedure is directly proportional to the size of the jerk on the other end of the catheter. And I think you can see that very nicely. And then here you see the shunt again and the resultant left to right shunt that improves systemic oxygenation. And as Dr. Rudolph had talked about this, I think it's almost redundant for me to emphasize that the shunt at atrial level is much more beneficial to the blood flow to the brain and the heart than when the flow is coming across at ductus level. And this is what one wants to achieve in terms of good mixing in a patient with transposition. We can always identify the ductus. Here you can see the ductus from a variety of views. Here we can already start to see this spontaneous closure of the ductus beginning at the pulmonary end of the ductus over here, with acceleration occurring at this point over here in the ductus. And later on, if the ductus closes, you can see again the little diastolic flow as the pulmonary artery pressure has fallen of the flow in the ampulla of a small ductus still present. I said I wasn't going to talk about coronary arteries, and in the interest of time, I'm not. I'll see this tomorrow or the next day. Okay, so now operations for transposition. The most important operation, obviously, is the arterial switch procedure done early in the neonatal period. It's in a graph, it's a very simple procedure. The arteries are transected. The coronary arteries are excised as buttons, okay? And then the ductus is ligated. That's very important. The ductus is ligated in order to pull the pulmonary arteries through to the old aorta. Okay? And that, I think that's terribly important, because often in this condition, Dr. Rudolph didn't actually mention this, but there are frequent bronchial collaterals in this condition. And if you have got a good color Doppler signal, you're going to see a lot of, somebody had asked me this question yesterday about flow from bronchial collateral vessels that may look like a ductus arteriosus. And I think if you really want to avoid making a fool of yourself, don't tell the surgeon that the ductus is still open. Rather call them bronchiocollateral vessels, because in order to do the switch, they have to ligate the ligament to pull it and divide it in order to pull the pulmonary arteries through. So part B of the operation here is the, generally speaking, the buttons surrounding the coronary arteries are dissected free, and they, as the aorta is now connected to the old pulmonary root in the area. It's not generally done like this through separate areas, but it's done within the suture line. The pulmonary artery, the coronary arteries are placed within the suture line, and then after the pulmonary artery is closed, the old pulmonary root is closed to the aorta. The pulmonary root is then closed to the old aortic root using a patch technique to augment where the buttons were in place, and that, Bob's your uncle, is the end of the operation. So now we have to evaluate what happens after the switch procedure. Well, obviously left ventricular function is important. I'm going to leave all of the important information on this to Mark Friedberg, but just to say that if the arterial switch is not an excellent procedure, the surgeon knows about it immediately, because the heart doesn't squeeze very well if it's ischemic after coming off bypass. Generally speaking, because of the accumulation of metabolites in the circulation at the time of operation, you get coronary vasodilatation, and when you use color Doppler flow, you can see a lot of coronary blood flow within the coronary circulation in patients with this condition. So not only do you see that the function is okay, but you can also see this marked increase in coronary perfusion related to autoregulatory phenomena. So we check, obviously, besides the function, firstly, the coronary anastomosis, the proximal anastomosis of the old pulmonary route to the aorta, and the right ventricle to the pulmonary artery. We look at the aortic arch. We look at the pulmonary valves, and we look for residual. We'll check to see that they've closed the ASD, and we check for residual and undiscovered lesions, which we do anyway, and look for the presence of effusions and diaphragmatic palsies after the switch procedure. So here's a patient who's immediately after the switch procedure, and as you can see, this patient has got a small muscular ventricular septal defect, which was recognized beforehand and was elected to be left alone, as this natural history of this lesion is a very high spontaneous rate of closure. Now, because function is somewhat compromised after coming off bypass, there is a minor degree of mitral as well as a moderate degree of a tricuspid regurgitation present in this patient. We check the aorta and the pulmonary artery. Here you can see the button. You see the suture mark on the button of this coronary artery, which was transposed back here, and we can look at the other one as well. We often, well, I won't say often, but we occasionally have patients that can't be transferred. This is the so-called Aubert procedure, where the pulmonary trunk is connected through the anastomosis, and the coronary artery cannot be moved, so it's left on the pulmonary artery. And here is such an example of an Aubert procedure. Here's the aorta. Here's this flap of pulmonary valve tissue going into the neo-aorta. Unfortunately, I've only seen 2 patients with this condition, and one landed up with this result. Okay, we look at the presence of associated abnormalities. Here's a patient who is surprisingly has subaortic stenosis. This is looks like it was done in the operating room. We check the size of the aortic root, and particularly in a longitudinal basis, this is important because big old pulmonary arteries, particularly those where there was a ventricular septal defect, tend to enlarge, and they can be problems just as the aorta can be a problem in tetralogy of Fallot, as Dr. Hasbani showed us this morning. So you have to follow the size of these vessels and make sure that they don't get to the stage where they might give rise to more than trivial insufficiency and question of dilatation related to the presence of dissection or rupture, as one would be concerned in Marfan syndrome. Now, when we look at the aorta, we look at the ascending aorta from the valve through the ascending aorta down the arch to make sure there's patency. The pulmonary artery is seen in front of the aorta because of the switch procedure. It's the only time where the pulmonary artery runs in front of the ascending aorta. We look at this from below. We can see in this patient that there is a little valve problem that's not infrequent here. We look at the branch pulmonary arteries here, and we measure the size of the branch pulmonary arteries. This not necessarily immediately post-operatively, but continuously during our post-operative evaluation of these patients to see what happens to the size of the pulmonary arteries. And I think that this is certainly not only institutional but surgical, surgeon-related, that some surgeons have more problems with their peripheral pulmonary arteries than others. When I asked our surgeons how they avoid the problem, they dissect way out onto the vessels. When you pull a vessel or you pull a rubber tube, you narrow the caliber of the rubber tube. So you have to continuously watch out for this. But unlike a rubber tube, these vessels have the potential for growth and sort of enlargement of these structures as time goes by. And if they don't enlarge, they can create a problem that may need further intervention either by cardiac catheter or by means of a surgical augmentation. Usually the latter after the former. Here we're looking at the RV outflow tract. I beg your pardon, the RV outflow tract, the neo-pulmonary artery and the vessels. The left pulmonary artery runs to the left of the aortic root, the right to the right of the aortic root. We watch to see whether we can see stenosis or insufficiency and evaluate that for ongoing evaluation to see whether that's good or bad. And here's an angiographic example, of what an anastomosis looks like. And you can see there's a proximal narrowing here just distal to the pulmonary valve. And here are the bifurcation of the vessels with the aorta running behind this over here, but not highlighted because of angiography. And here's an echocardiogram showing the French connection with the right and left pulmonary arteries arising off this neo-pulmonary artery here. Here's the aorta in the crux of the so-called trouser legs of the pulmonary arteries, and you can see a little acceleration within the branches, nothing much, but obviously we measure this as well as look at the caliber to assess the size of the pulmonary arteries and the degree of pressure drop that may occur across these areas. And you can do this subcostally. Here's the aorta, and here's this narrowed pulmonary artery that you can see going to the left-hand side, bifurcating into an upper and lower lobe vessel on the left side. Now, I know that Dr. Asbani is going to talk about this, but many of our older patients that we're still following that have had transposition have had the atrial switch procedure, either the mustard procedure, which is done with the pericardial patch, and the pericardial patch is placed around the pulmonary veins on the left side and up to the superior vena cava, then round the back of the pulmonary veins the other side, and down to the inferior vena cava, so that the patch then is a conduit between the superior and inferior vena cava, and the pulmonary veins are underneath this patch, as you see them here, and the pathway is from the pulmonary veins across this narrowed area over here, which is called the isthmus, and into the tricuspid valve. And as this patch surrounds the pulmonary valve, the superior and inferior caval veins drain into the mitral valve. The setting is a little bit more complicated. They excise the atrial septum, and then they patch the pulmonary veins through to the back of the atrium. They then put in a little incision in the lateral part of the atrium, and here are the pulmonary veins distal to that. And they then take a pericardial patch or a patch of atrial tissue and extend this round so that the pulmonary veins are then draining to the tricuspid valve, and they extend and close this patch, and then the superior and inferior vena cava drain to the mitral valve, and the atrium is augmented with some kind of tissue so that this area is not very narrow. Now, the good news and the bad news is they look pretty much the same when you see them after operation. It's not easy to recognize which operation the patient has had by what the echocardiogram looks like. And here you can see, here you can see the pulmonary veins here. This is that part of the left atrium, and it comes across this little narrow area which we call the isthmus, and then it drains into the sinus proximal to the pulmonary valve. So the superior and inferior vena cava come through from the blackboard, as it were, into this area here, and then this surrounds the mitral valve. So you have two C's when you have this operation. One draining the superior and inferior vena cava into the mitral valve, and the other one draining the pulmonary veins across the isthmus and into the tricuspid valve. And so that's how we fool Mother Nature, or at least the surgeons do it that way. And I think from a four-chamber view, that's really quite easy to see. Problems occur with Senning and mustard. Leaks across the baffle are quite frequently discovered. You can see here the AV valve on the right side, the systemic AV valve and the tricuspid valve is already demonstrating a leak. And it looks like this patient also had a ventricular septal defect with a little left to right shunt across a residual patch leak. Now, you can get problems with the baffle, and you can get pulmonary venous obstruction at the origin of the pulmonary veins. You can get it also in this area here. This is a patient that we had that had a very high continuous velocity across the area of the isthmus. This was actually handled successfully with a balloon and dilated, and all the pressure dropped down below, and there was no increase in the incidence of shunting across the procedure. I won't talk too much about the Rastelli procedure, but it's done when there's a ventricular septal defect, and the ventricular septal defect is usually connected to the aorta, and the pulmonary artery runs passively across this. This is what we use with the Taussig Bing malformation. Now, this is an example of obstruction to the upper end of the baffle in a patient with a mustard or an atrial switch procedure. And I think this was a Senning, to be quite honest, because at this time where this was done, the Senning was in vogue. And you can see here that because of the blockage at the superior caval end of the baffle, that the blood is actually traveling through the azygos vein and down towards the inferior vena cava. And clearly that this is a problem, because, again, blood should flow towards the heart and not away from the heart. We devised a series of tests which I still think are valuable in terms of looking at shunt flow. And here are 3 cartoons to show the baffle presence here. And if you give a saltwater injection with microcavitations and there's no obstruction to the superior limb of the baffle, then all the blood goes through the baffle and into the left ventricle and then to the pulmonary arteries. If there's some obstruction at the SVC limb here, what happens is that there's some retrograde flow down the azygos vessels and into the lumbar vessels, and then it comes back here. Now, if the obstruction is only partial, then there's some flow that comes forward as well as backward across the inferior vena cava. And if you just examine this part of the atrial septum with your with the ultrasound system, you usually will see this reflux coming down towards the mitral valve. Now, just let me point out to you that this is quite a distance for microbubbles to travel, and so you have to be very patient in looking for this. You can't just give the saline injection and expect it to be there in 1 beat. It will often take 3, 4, or even 5 beats to get down, depending upon the size of the patient. And when there is complete obstruction, then all of the blood goes down through the azygos system and comes up from below. So we'll show you this, how you can tell this with contrast echocardiography very easily. And we segregated our patients with this problem many, many years ago into patients in where the SVC pressure was under 4. In this circumstance, the SVC pressure was 4 to 8, and here the pressure was always over 8 millimeters of mercury. And of course, long-term obstruction with elevated venous pressures does not do very good for continuous brain development. So here's a contrast injection which we will run as a sequence over here. It's a superior caval injection, and you can see even from the direction of the travel of these bubbles that exclusively they are coming from the inferior vena cava. So this is a patient who's got total obstruction, and it's a very easy test to do, provided you give a adequate bolus of the contrast material into appropriate venous structure. So that's pretty easy, and you can even see the reflux down into the hepatic veins in this patient. So now just a few words about double outlet and the associated list. I mean, when you look at double outlet, I mean, it's really one of the conditions which has got a whole series of associations, inferior vena caval interruption, in left isomerism, left superior vena cava, the coronary sinus with the systemic veins, the atrial atria, they have atrial septal defects of all kinds, isomerism of the atrial appendages, absent atrioventricular connections. They may have tricuspid or mitral or both anomalies or atresia. They may have double orifice of the valves, straddling valves, pulmonary veins, either total or partial. Their ventricles, all types of VSD, outlets, subaortic, subpulmonary obstructions, a presence or absence of the aortopulmonary septum. They have coronary artery anomalies in higher numbers than they get in transposition. And of the great arteries, they may have coarctation, aortic arch interruption, or pulmonary arterial and valvular abnormalities. So our experience at Stanford when I worked there, of 168 cases, surprisingly, there was a very low incidence of patients with subaortic ventricular septal defect. With pulmonary subpulmonary defect was a much higher incidence, 51%, of which the majority had no pulmonary stenosis. There were 4% doubly committed and 15% were non-committed. Usually these patients are referred for a univentricular kind of repair. When we looked at our experience from fetal diagnosis, we diagnosed 19 patients in a similar period at Stanford in our fetal laboratory over there. There were 3 patients terminated, so that left 16 where the pregnancy continued. Somehow some of them got lost to follow-up. Presumably they didn't come back to our institution, and we can't verify whether they actually went to other institutions, died, or had the pregnancies terminated. Postnatal examination was possible in 13. Because of the associated abnormalities, some died without surgical interruption, 5. That left 8 patients who underwent a surgical palliation. Some of them actually underwent single ventricular palliation, 5, of whom 2 died and 3 survived, and 2 underwent a biventricular repair, and 2 died and only 1 survived. So not a very happy association of double outlet right ventricle. And we talked about the Rastelli procedure, and I got this slide, which I proudly stole from Stephen Sanders. And this is better than the slide that Steve showed, because I think that what this does is it tells you the whole story of double outlet. And if we look here at the doubly committed type of VSD, which is the template for all of these pictures over here, you see if there is no infundibular septum over here, that the VSD is then going to be committed to both the pulmonary artery and the aorta. And once again, if this defect is like this, their vessels don't change their position and the VSD doesn't change its position. So the classification that we have is a classification based on how we associate the defects with the ventricular chambers. And as Steve has pointed out, it's this red infundibular septum which changes how the lesions appear. This is where the papillary muscle of the conus is, so we call this conus septum. And if the septum is deviated in this direction, it brings the ventricular septal defect into a subpulmonary position. And if it is deviated towards the pulmonary valve, then it brings the aorta into a subpulmonary position. So just let's look at a couple of these. And here's a patient whom you see the VSD. You see the aorta is over here. The pulmonary artery is here. This is really, the VSD is immediately under the aortic valve here. You see that there. Okay, so subaortic ventricular septal defect. And we can follow that as well. Here is just let me look at this one with you first. Here's the left ventricle. Here's the deviated outlet septum. And the outlet septum is deviated towards the pulmonary valve. So the aorta is likely to be closer to the VSD. Now, one of the problems that we have that perhaps Girish will be able to show us is that the ventricular septal defect is into the screen here. It's more posterior. So this pulmonary artery tends to be walled off from the flow. So this is a subaortic ventricular septal defect. And you can see the ventricular septal defect underneath the aorta over here. This is pulmonary artery. The vessels, as we say, are in the same position. So that's another example of a subaortic ventricular septal defect. Here is an example of a subpulmonary VSD. The separation between the mitral and the pulmonary artery over here. Here's the outlet septum. Here are the coronary arteries. And we see how you define the VSD is not over here really, but over in this region over here. And I think that one of the things that's terribly important and one of the reasons why the surgery was so much of a problem is that the papillary muscle of the conus is frequently attached here, and so that in constructing a repair, the integrity of the tricuspid valve has to be challenged as well. Get very upset when the surgeon leaves when you're talking about surgical lesions, but I guess that's life. Okay? I never walk out on the surgeons, but they always walk out on me. So here's a subpulmonary VSD, and here again you see the VSD, and here there is no obstruction over here. The aorta tends to be walled off from the ventricular septal defect over here, and here's the pulmonary artery. And in a way, the septum is malaligned almost in the other direction, and many of these patients have subaortic obstruction, and with the subaortic obstruction, because of Dr. Rudolph's theory of flow, if there's less flow out the ascending aorta, then the area across the isthmus and the area of, where there might be coarctation is certainly something to consider as a challenge, and as well from the point of view of understanding the pulmonary, I beg your pardon, the second heart field and the flow from the neural crest mesoderm is that that message gets all messed up, and that's why they may have, oh, thanks for coming back. They may get interruption of the aortic arch in a number of these patients. So that's a subpulmonary ventricular septal defect for you. And when the outlet septum is malaligned, here you can see the papillary muscle of the conus attached to the crest of the septum. Here is the ventricular septal defect. Here's the pulmonary artery. Here is this aortic area which is narrowed. Again, you don't see the ventricular septal defect in 2 dimensions because the defect is deeper here and underneath the pulmonary artery, which probably Girish will be able to show us on the 3D study as well. And this is a much more profound example of subaortic obstruction here. The septum is completely deviated. There's callus formation underneath the left ventricular outflow tract. Huge pulmonary artery, small aorta, also associated with a ductus. This is a patient with aortic arch interruption and subpulmonary obstruction. And here, one of the reasons why the Rastelli operation doesn't work very well is you can see that the papillary muscle of the conus has all of the tricuspid valve tissue attached. And certainly when I spoke to Aldo Castaneda, that was one of the things that he was most concerned about in the echocardiographic diagnosis of double outlet right ventricle. Now, again, we see a fair variety of patients where there's doubly committed VSDs, and here is a patient with a doubly committed double outlet right ventricle, no infundibular septum. The aortic and the pulmonary valves are in fibrous continuity, one with the other. Here we can see it from the subcostal region. Here is the aorta, here's the pulmonary artery, a little bit deviated outlet septum. Here's the pulmonary artery, here's the aorta. So a doubly committed double outlet right ventricle with some acceleration of flow underneath the pulmonary valve. And lastly, the non-committed variety, very frequently AV canal defects, sometimes muscular inlet ventricular septal defects with a true double conus arising from the right ventricle and no egress from the left ventricle. And the VSD, rather than calling it non-committed, I like the word remote to explain it because it's impossible to get to that area. So I think that's all I have to say on the subject, and I'd like to invite the next speaker to come up right now and look at that. One last picture here of a non-committed double discordance, AVVA disconnection, and very, very remote ventricular septal defect. The ventricular septal defect is here, and the vessels are way, way away from this lesion. Okay, now I'm done. Thank you. Let me help you, Girish.
Break now and then come back. Just 10 minutes.
Yeah, sure.
So we make a 10-minute break now. We are a little bit over the time. Probably so just stand up and get some.
Sorry, I didn't mean to do that to you.
So I tried to find the
I'll do it for you.